Hey, welcome everyone. Um, Welcome to the webinar from Birthing the Magic Collaborative on gestational diabetes. I am so excited, and we are so excited that over 190 people registered for the webinar and the presentation by Dr. Cassandra Henderson. Before we get started, I do want to remind everyone that for nurses, this webinar will count as one continuing education credit. And for doulas, you will receive a certificate. With that, I want to have a brief introduction of myself. I'm Kelly Malone. I currently work in the aerospace industry. However, I have a PhD in chemistry, and I worked on microelectronics for over 25 years before I moved into the aerospace industry. I'm a mom of 2 kids, and I went back to school at 52 to get my MBA. And I met Marie and her Birthing the Magic Collaborative as being her passion. And I also feel very passionate about safe births for Black women and Black children. So with that, I'd like to introduce Dr. Cassandra Henderson. And she has a phenomenal bio. And so if you guys don't mind, I'm going to have to read it a little bit, but I'm very excited to introduce Dr. Henderson. Dr. Henderson is a board certified maternal fetal medicine physician and diabetologist who holds a master's degree in diabetes education and management. She's also a certified diabetes care and education specialist and a CDC certified lifestyle change coach. Dr. Henderson is deeply involved in leadership within the field. She currently serves as the chair of the OBGYN section of the National Medical Association and chair of the Pregnancy and Reproductive Health Interest Group of the American Diabetes Association. Dr. Henderson is dedicated to breaking down complex clinical topics into plain language to make more sense for all practitioners and patients. And with that introduction, I'd like to ask you, Dr. Henderson, if there's any additional background that you'd like to share with us. And then after that, if you can answer the question, what is gestational diabetes?
Well, thank you very much, Dr. Malone, for your wonderful introduction. I hope at the end of this discussion, we will all be able to agree on what is gestational diabetes. I'd like to thank so much this opportunity to talk to everybody, and I really, really, really appreciate you taking your time on Tuesday evening to sit and talk and listen to me about talking about my passion. I really, really do believe that gestational diabetes is a real, real opportunity to improve the health of many women who are who are in position to be improved by just our intervention, non-invasive, non-complicated intervention. So thank you so much for taking the time to listen to me. I'd like to start with a little housekeeping. One, I want to make this as interactive as possible. If you would please have your phones with you if this is possible, or if not, we actually put some QR codes in the chat. You can use the chat. I understand that's another way of doing it. So I'm going to have some questions just to get to know each other and know where we are and just kind of help us to be more of a group, even though we're spread out all over, I'm not sure where, but many, many places. So I'd like to start with the first one, my slides. Let me go back. Are you seeing my slides?
Not yet, we don't know.
I did everything except this. Okay, now I need help.
Are you doing share screen?
I'm trying.
Hold on, let me see if I can make you.
I was so prepared.
Yeah, it always happens, not a problem. See if that helps.
I'm seeing it, but you're not seeing it, right?
Correct.
If maybe I email these to you.
That would be fine.
I do apologize. Can't tell you how many times
I'm not sure. And just for the doulas, we don't actually need your email address. That was someone else's post or comment about email. What she was asking is for me to share the email for you to request the certificate. I don't need your email address here. If you would email the address that I put in the chat, that's all you have to do. Unless you want people to stalk you, because this is in the chat now. But we'll take it out. And then I'll grab your email, Dr. C, and pull it up for you.
Okay, I'm just sending it. Do you see that?
The email, not yet. I'm waiting. Oh, there we go. I've got it.
I do apologize, everybody. I really did practice
Oh,
all of
Dr.
this.
C, we are not.
Everything was all set up.
I should have had you test it when we were testing mine. I'm getting it loaded first. We'll just talk amongst ourselves while we're
Okay.
waiting for it. Hold on.
Well, I'm
So
going to
what
the
made
first
this your topic of interest while we're waiting?
well, the first slide that I had, really, we could actually talk about that. One, I just wanted to know where you're from. So you started doing that in the chat. So if you would put that in the chat, that would get over the first slide that you don't see, and hopefully you will see it soon. So if you could put where you are located, what geographic area would be great. If you could share that so we know where you are. The next The next question I had, are you a morning person or an evening person? That will help me to know how loud I have to talk to keep you awake. So those are some of those was going to be my slide questions while I started talking if I just didn't know that I couldn't share my slides. I do apologize. Is that
I
at all?
did you have a lot of images in here, Dr.
I
C?
do, I do, I do, I do.
Let's try yours again because I think that's why it was just taking a while.
How do I do that though? I don't see
Um,
where.
do you see the share screen button, right?
I do
Click,
not.
click that, and then it should
I do
pull up.
not. I do not. I do not see a share
Oh,
screen.
you don't see it. Oh,
I see slideshow, record.
Marie, I have the share button. If you don't mind,
because
if you send it to
it's
me,
not
I'll try
opening
to
for
pull it
me.
up.
Okay.
Yeah.
Between the three of us, how many
We'll
does it
get,
take?
yeah, how
Oh,
many?
wait. I see share. I see share. I see share.
Ah, okay.
Wait. I see share. Upload. But you still don't see it. Oh,
It
this
may
is
take a
terrible.
while because it's taking it that long to load on my computer with the images, but we're in a rural area, so
Hi, I'm not. I am so sorry, everybody. I really did practice this so many times.
we give grace, don't we, in our village? So we're not going to stress. It's not
I
even
see
letting me
slideshow. I
download
see
it.
record. I don't see anything here that says share. I see share, but
Um,
it doesn't.
on
It's
on
share
your Zoom
link.
screen, on your
But
Zoom
it's
screen.
share. No, it says share. I'm in PowerPoint.
Oh no,
And
go back to Zoom where you can see yourself.
I can see myself.
Okay, and then
Share.
look under your picture. Do you see the little
Is
green
share.
share?
Yes, I do.
And then now it should come up and show any screens that you have open.
No.
And then you pick the window that you have. That is strange that it's not letting me open it. And I can't even forward it to you now, Kelly. It's got me locked.
Oh, maybe it's encrypted or
Oh my gosh, I'm so sorry, everybody.
No. Take a deep breath. We're going to make this work.
yep. You can't forward it, Marie.
My screen had locked with it. Let me try it. I'm doing a restart real fast.
Oh,
There's screen.
Girl, you must have a whole lot of pictures in here.
I do. It was a great presentation. Honest to God, if you guys would
There
just
we go.
hold
There we go.
on.
We got it. We are in. We're good. We're in. Okay. And
So you're going to share it, and I'm
I'm
going
going
to
to share the screen and you'll just tell me when to.
the next slide.
Yes. There we go.
I do apologize, everybody. Honest to God, I practiced this so many times.
And it finally opened. It took it that long.
Okay, so we're good now.
Yes.
Can everybody see?
yep,
Here
we
we
can.
go.
Okay.
Yes.
Oh, thank you. So sorry. So the first one, can you see this? Is it big enough to do
Yes.
the QR code?
And then go to the first one. There.
Okay. Go. The QR code. The first one, are you a morning person or a night person? If you guys could Did you get that one? Can you scan? Do you use your phone to scan that? Are they able to see that?
Well, the thing is, I can scan it, but then now I can't drop it in the chat because, no, wait, I've got it. If you guys aren't using your phone, we will drop the link in the
Can the
chat.
picture be bigger? It's small. That's as big
Oh,
as we can get?
I've got it at full screen. What do you guys see?
I see like your desktop with
What is everyone else seeing?
does everybody see a full screen?
Uh,
No, it looks as if you've opened it in the web browser and
oh,
Yeah.
it
hang on.
hasn't
Oh,
downloaded.
oh, wait. Let me redo it.
Yeah.
Sorry. If anyone on this call is a tech savvy person and in the United States, would you like to volunteer with us? We've
That's
got
it.
tech
Okay,
savvy
now I
people
see it.
in the
It's good.
United.
It's good. It's
Okay.
good. Go back. Go
Okay.
back. Go
Yeah.
back. Okay, we got it.
Uh,
All right. So we have morning people. Good.
wait.
Thank you. Go back. Back.
Am I going back
Back.
or forward?
Back.
Wait,
Back. 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 Back.
hold on.
Back. 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 Okay, good. Thank you. I
Okay.
am so sorry, everybody. Thank you for holding on there. I do so apologize. And what are we doing? It's not me. Who is that? Oh my God.
That is
Sent
you
you the
right here.
wrong one. But that was during my practice. Ay, Jesus Christ. Okay, send the next one.
Yeah, big bet. Okay, here we go.
Oh my God.
Is
Okay.
this where we want it? This is
Yes.
the slide. Okay.
Okay, this is good. So we can start here. Those we just do this on another screen. So we got morning person and know where you guys are from. So what I want to do is to talk about this is our agenda. We're going to talk about gestational diabetes. How is it diagnosed? What is it? How do we screen for it? What are the three pillars of gestational diabetes that we use to manage gestational diabetes? And what do we do after gestational diabetes? I do so apologize. Honest to goodness, I was ready for this. Anyway, we're moving on. I'm going to be hopefully catch up with the time. Um,
And we
there,
have no one after you, so there's no rush.
the other thing I wanted to go back.
Oh,
The other thing that I wanted to talk about is that as important as gestational diabetes is in managing during the pregnancy, it is so critically important and something we miss a lot after the delivery. I think it is such a perfect opportunity to manage individuals after they have diabetes, and it just helps so much. We take this out. I'm on the next one. Oh, I got the wrong slide. But anyway, go ahead. The next one. I sent you the wrong thing. Okay. Um, what got me interested in gestational diabetes is when I learned that having a heart attack, most people would know that if you had a heart attack, you're much more likely to have another heart attack. Having gestational diabetes increases your risk for having a heart attack just as much as if you had one previously, which just kind of blew me away. I then knew, of course, that having gestational diabetes increases one's risk for developing type 2 diabetes by about 12-fold. So it's a significant increase. And more importantly, we know that exercising 150 minutes a week and reducing your weight by 5 to 10% or 15% will decrease your risk of developing type 2 diabetes by 66%. So knowing that, it just seemed to me that that is an opportunity to make a difference. And I think a lot of times we just missed it. So I got really passionate because I wanted to be able to help people understand that there's an opportunity to alter their life. We know that diabetes is a leading cause of blindness in the US. We know that it's certainly a risk from myocardial infarction and also the leading cause of non-traumatic amputation. And many of those things can be prevented if we institute some of these changes. The next slide I wanted to ask is what word comes to mind when you think of gestational diabetes? So if you will put that in, if you can have your phone, and if you have a phone, please scan that and enter this. What do you think of when you think of gestational diabetes?
we're seeing a lot
And
of.
as I said earlier, that I wanted to use the time when you're answering these questions to try to answer any question that you might have in the chat. So while you're trying to answer this, can anybody see this? If you scan it, do you see the question, what word comes to mind? Because it doesn't seem as though any questions. Nobody sees it? High risk pregnancy. So you're putting in the chat, there's a
Yeah.
Mentimeter.
Some of them are saying that they're on their phones, Dr. C, so they're not able
Got
to
it.
scan it.
Okay, got it. Okay, we're good. So I see So this is, I got it. Okay. I need to move forward. I did. Back. Okay.
And they are answering it in the chat.
Super. Got it. Okay.
And I can read them to you.
Okay. So I see it. This is good.
Oh, you see it. Okay.
Put the chat. We got this. LGA. That's good. Insulin. Insulin's really, really important and high risk for mom and baby. Great, great, great answers. Those are things we're going to talk about. Absolutely on point. So the next slide. One of the things I wanted to talk about during this session is to share with you a book that I really just think is so cool. It is a journalist who actually wrote a book that has 66 things you should think about with food. And his name is Michael Pollard. What he really was passionate about is the whole agriculture, economy, commercialization of food. And what I think, while it does not directly address diabetes, it certainly is an opportunity, it's a tool, I think, to help you think about food and making choices that might be better for you or slightly healthier. So I think it's a good thing. So I'm going to give you some of his words of wisdom throughout the presentation. And if you would there's another QR code, but you can't, let me read this then. Uh, the next question, if you can't read the QR code, is, well, I don't know how you do this. Well, anyway, somebody's filling this in. Good. How well do these statements describe your gestational diabetes knowledge? So a lot, not so much, less. So if you answer that on the code, and we need to go back to the slide with that. Okay, so one of the first things I'd like to share with you that I thought was really cool, Michael Pollard, one of the one of his quotes is, avoid breakfast cereals that alter the color of your milk. If you think about that, I mean, you put in Cheerios, you put milk, and it stays the same thing. Other cereals, you put milk and it changes different colors. So, I might want to think about that. Not that it's bad or good, but just something to think about when the milk changes color with your food. The next one, next slide. So language matters. And I really would like to bring home the point. It doesn't, even with good intentions, language can do not great things. One of the things we often do when women have glucose screens, they say, and often healthcare providers say to them that they failed the glucose challenge test. We don't say fail about any other screen. We don't say with non-invasive prenatal testing, the prenatal screen, we don't say you failed this. We say that your child is at increased risk for having a genetic abnormality, and we do another test. So it's not that they failed the glucose challenge test, it's that it is elevated and they have a higher risk for having diabetes. And we then do a diagnostic test in order to determine whether they have it or not. But they didn't pass or fail. And I would hope that we could get away from that, because it starts the whole process of diabetes with blame, and just it makes it even more difficult than it needs to be. And so I would hope that we could say that the glucose challenge test was elevated, or just a simple fact, you're at increased risk for gestational diabetes. We're going to now do a test and see whether you have it or not. The other thing is, we often talk about glucose control. Well, many know that no matter how hard you try, you cannot control diabetes, glucose. Oftentimes it's whoever cooked it. Maybe it's different. Maybe you don't feel so well that day, or maybe it's warm in the room, and as a result, your glucose is going to be elevated. But it's not that you control it or you don't control it. You either achieve your targets or you met your targets or goals, as opposed to controlling or not controlling diabetes. The other thing about words, individuals are not diabetic. They have the disease. They are someone who was affected by the disease. They have diabetes, but they are not diabetic. That does not define who they are. And knowledge about, well, many people don't have the screen. The question is, I'll read it. How much do you think you know about diabetes? Do you think you know how it's treated? You know a lot about it, just to where you are in knowledge of diabetes. And the next slide. One of the things too about words is sugar. Sugar is stuff you put in your coffee or your tea. It is not the fuel that the cells need. Cells need glucose. And when we're managing diabetes, talking about diabetes, we're talking about glucose and not sugar. And so I would hope that we focus on the concept that we're talking about sugar and not glucose and not the sugar that we put in coffee and tea to address that. One of the concerns is just how rapid, and we'll talk a little bit about glycemic index. Some foods really rapidly increase your glucose and others do not. But you can also slow it down a little bit by combining it with water so that your kidneys can get rid of some of the excess glucose or combining with proteins or healthy fats. And the next slide. What is gestational diabetes? It is diabetes that initially is diagnosed during pregnancy. It gets a little tricky because some individuals don't have health care or have never gone to a doctor or do not believe in having bloods drawn. So they may not know that they have type 1 or type 2 diabetes. And unfortunately, that may not be diagnosed until they're actually pregnant. And that sort of muddies the water, but you can help sort of parse that out depending on when it's actually diagnosed and other factors. But in general, it is generally considered diabetes that is diagnosed in pregnancy, and then normally is diagnosed between 24 and 28 weeks is usually when we do the screen because that's when the placental hormones are at max, and that's when we would make sure we don't miss anybody who has gestational diabetes. And it generally resolves after delivery, specifically after the placenta is delivered, because most of the cause of it is the source of the placental hormones. Next slide. One of the issues with gestational diabetes, it can become, the mother develops either a higher risk for developing hypertensive disease of pregnancy, preeclampsia, or they ultimately end up having a higher risk for cesarean delivery. The cesarean could be because of the preeclampsia or the hypertensive disease, but most often it's because the fetus is large. And the fetus is large because of the hyperinsulinemia. Fetuses that in response to elevated glucose in the mother, the glucose crosses the placenta, the fetus cannot tolerate high glucose, so they urinate a lot, and so all that urine is amniotic fluid, so there's higher amounts of amniotic fluid, and then ultimately they start to produce their own insulin. And the insulin is growth hormone, which causes the fetus to be big, and ultimately the newborn to be large. They can be 10, 12, 14, 16 pounds. Obviously, that's traumatic for the mother, but more importantly, I think the fetus, once it's born, can't just stop making insulin. So the neonate continues to make insulin, has the risk for being hypoglycemic and ultimately seizures, and without treatment can go on and die. So those are some of the concerns. During the pregnancy, the baby can be big, but then after the pregnancy, there's obviously problems with being big, but then the continued hyperinsulinemia can result in severe morbidity and mortality for the neonate. We do the next one. This is just a picture of the fetus developing hyperinsulinemia. The mother's insulin is decreased, and that's pathologic, leading to increased hyperglycemia, which the elevated glucose crosses the placenta to the baby, and then the baby in response produces insulin, which can lead to macrosomia, or large infants. Next slide. So how do we diagnose gestational diabetes? In the US, we do two steps. We do the glucose challenge test, which is what I was saying. Please do not say that they passed or they failed it. It's a glucose challenge. It looks at how glucose is handled and whether the individual's at increased risk for having gestational diabetes or not. And the only way to make that diagnosis is with the glucose diagnostic test. That's 100 grams of the glucola and then 3 blood glucose draws to see if they have diabetes. In most of the world, they actually do a one stage with a 75 gram. We generally tried not to do that, primarily because the thought in our country was that it identified too many people. So the thought was we were burdening people with the diagnosis of gestational diabetes when they really were not ill. And it also had others, it caused just workload. Many people had to manage the gestational diabetes, and ultimately, it was decided that we went with the two step. The problem is that sometimes it's really difficult and a burden for women to come back for the second one. And also, I just think it's not for me. I don't think that's a negative to know that you're at increased risk, because then that gives you an opportunity to change your habits. But nevertheless, in the U.S., we do the two-stage. The next slide. The three pillars of gestational diabetes are dietary management, which is the primary one, and the second is physical activity. And then finally, we use glucose monitoring to see where people are and to actually help. It is a good feedback to know if what works and what didn't work and what can be adjusted. Then let's see, did anybody scanning? Is this working? We're not doing this. Okay, then I should read some of these. No, it's not working. Thank you. So the QR codes are not working. That's a shame. Anyway, so this was one of the questions. What is not a standard first-line treatment for glucose GDM? One is healthy eating, physical activities, blood glucose monitoring, or immediate insulin administration was one of the slides. So none of the QR codes are, no. What is not a standard first-line treatment?
We can
Insulin.
answer in the chat, however.
Okay, immediate insulin is not the standard first-line treatment. Okay, next one. It is important to know that it is not a moral failing or something that someone did that caused them to have gestational diabetes. It is a result of the placental hormones. It is true that there is generally some underlying risk for it. The risk for gestational diabetes, the same. Oh, okay, well. Still no QR code, not working. Sorry. In normal pregnancy, there is some insulin resistance because that results in more glucose in the maternal blood that goes across the placenta to help the baby have enough nutrients. In women who have gestational diabetes, that normal insulin resistance goes too far. Their pancreas does not put out quite enough insulin to make up for the normal insulin resistance. As a result, their glucose is elevated. Thank you. I'm sorry. I hate, yes. And so as a result, they develop they develop diabetes because just from the pregnancy, because there is normal insulin resistance that goes along with pregnancy. That's why there's extra blood glucose in the maternal blood for the baby. But when that system does not get associated with an increase of 40 to 50% production of insulin from the mother's beta cells, that results in elevated glucose, and therefore they have gestational diabetes. Usually, when in normal pregnancy, in response to that insulin resistance, the mother's beta cells from the pancreas produces more insulin so that they don't develop hyperglycemia. But in that case, when they do develop not enough insulin, they do develop gestational diabetes. It's interesting that the same things that cause the risk for gestational diabetes are the same things that cause the risk for type 2 diabetes. So it's over obesity and other cardiovascular conditions. So those are the same complications. Thanks. The next. I do apologize. This worked so well so many times. Then another QR code. This Mentor meter thing is a pain. Okay, so the other thing is the one Mentor meter can gestational diabetes occur any other time than pregnancy? No. Gestational diabetes is very, very common It in the US is somewhere in the 4 to 6%, but in some populations as high as 10%. And in some places in the world is higher than that. It is due to the placental hormones, but there is an underlying predisposition to develop it, as I said, because most of the time the mother's beta cells from the pancreas can produce enough insulin to increase and correct for that insulin resistance that's normal in pregnancy. Let's see. I wanted to do slides when I was doing the Mentimeters. I want to answer questions. Well, I do apologize. This is not working. Okay, next slide. I had great plans. So the idea is that insulin is the key to get glucose in the cells, and glucose is the energy that all cells needs to work. And when in individuals who have type 1 diabetes, there's an autoimmune condition where the receptors to the insulin going in, the receptors to insulin being able to attach and allow glucose in the cells is defective. As a result, there's elevated glucose and hyperinsulinemia, and that's characteristics of type 1 diabetes. They have no insulin. Type 2 diabetes have limited insulin, either is delayed or not quite enough, and that affects about 2% of pregnancy. But 90+% of all individuals who have diabetes in pregnancy is gestational diabetes. And that is, again, limited to the fact that they don't quite make enough insulin to make up for the fact of the normal insulin resistance that happens during pregnancy. Next slide. And in summary, the pathophysiology of gestational diabetes, there's not enough insulin being produced by the beta cells of the pancreas, and there's the normal insulin resistance that goes along with pregnancy to allow for elevated glucose for the developing embryo. And when that process doesn't happen, then there's an elevation in glucose. And then for the Mentimeter, one of the questions I wanted to have you answer is gestational diabetes is best described as what? And the answer is elevated glucose during pregnancy. Next slide. The summary of the insulin resistance, all the things on the side, the left, are the risk factors for developing gestational diabetes. And again, these are the same risk factors for developing type 2 diabetes. And on the right, normal insulin resistance that occurs in pregnancy. And generally that's accompanied by an increase in insulin secretion. And ultimately there's healthy everything. And gestational diabetes does not quite enough produce the secretion of insulin from the beta cells, and there are all kinds of other things that happen that increase the risk for problems in pregnancies. We now know that periodontal disease, the inflammatory changes around the body, can cause gestational diabetes to be difficult to have abnormal outcome in that the glucose tolerance, the glucose management is impaired, and as a result, the glucose continues to be high, and ultimately that leads to the fetal hyperinsulinemia. Next slide. In summary, these are the risks that we look for in gestational diabetes and what we're trying to avoid and to minimize. The individual has glucose intolerance during pregnancy. There's a much higher risk of hypertensive diseases, specifically preeclampsia, and then also the risk of cesarean. That some is from maternal complications from hypertension, preeclampsia, but mostly is from the large fetus. That is certainly a trauma, surgery, large, major trauma, but also perineal trauma. Delivering a 12, 14, 15-pound baby vaginally often leads to some trauma. So that's one problems with gestational diabetes. And on the other side, the fetus with the hyperinsulinemia, complications with having elevated amniotic fluid, polyhydramnios, but most importantly is the large fetus, the fetus that weighs more than 10 pounds plus. And then ultimately, once it's born, it can't stop making insulin. It ultimately then is at risk for severe hypoglycemia. Next slide. The screens we use, the 1 hour, as I said, this is the one that hopefully you will say to them that the result is elevated and they either have or do not have a risk for increased risk for gestational diabetes. In areas where there's a high prevalence, many patients have it, and you don't want to miss anybody. The cutoff is lower, less than 130, and after that, they are then recommended to have a diagnostic test. In areas where it is not as frequent and you almost never see it, which is probably nowhere, but the cutoff is 140. There are other ways of screening for it. If someone has an elevated fasting of 170/26 or they have a random of 200, they do not need a test. They already have diabetes. They do not need to be subjected to a glucose challenge test to make a diagnosis of gestational diabetes. They have diabetes already. Please do not do that. The other items on the bottom, the other tests, glycosuria is what we used to use in the 1950s and 60s but now we certainly know that almost all women have some glucose in the urine, so it's really a terrible screen. And then all of the other tests are available, but they haven't been validated for use in pregnancy. So those are ways that you can get a sense if for some reason you can't do the glucose challenge test, that at least you would have some idea that there may be something that you need to be aware of. Next slide. These are the standardized screens of the diagnostic test. If the screens are elevated, you do the 100 gram and then 3-hour glucose challenge tested with abnormal. If they have 2 abnormal values, then they have gestational diabetes. And if you're able to do the 75 gram, which I prefer, then just one value, either fasting or the 2-hour that you get are elevated, then they have diabetes. Next slide. So the major pillar is food, and what we do is to try to focus on carbohydrates. I have always thought when talking to an individual about diabetes, they give them a list of foods to eat, not to eat, and you could pick from this column 1 and 2 from that one. But I've always thought that's not maybe what you're eating. So it always made more sense to me to give some kind of template about selecting carbohydrates. And since most people don't walk around with a measuring cup, how do you figure that out? Well, hands are pretty much available. So if you look at your hands and things that fill up your whole carb, like those big bagels that we love in New York, that's about 60 grams. So things that fill up your whole hand, that's about 60 grams of carbs. So if you kind of plan a diet, that's 30 grams with each meal, and then 15 grams with the carb with snacks. And it's really, really important to have snacks. And I'll talk about that a little bit later. But it's important to have the meals. But just as important, in the between time, you don't need to go long periods of time with no food, because then you get hypoglycemic and then you get hungry and then you tend to eat more. But more importantly, even if you don't, all these mechanisms to move glucose from where it's stored in the muscles and other in the liver, so that your glucose gets back to normal. So it's out of your control. Your glucose will come back up, and if it's not, and most often it's higher, so you'll end up going hyper, up and down, up and down. So it's really important to have the snacks, even if you're not hungry. And what you want to do is to have snacks that are combined of protein or healthy fats with the carbohydrates. So 15 grams of carbohydrates is really important. 15 grams is 1 carbohydrate serving. And that's sort of how you kind of figure out the snacks. And then the meals, you get into 30 grams to 45 in your palm, and then your whole hand's about 60 grams. Physical activities, about 150 minutes a week. And you can certainly go to the gym and do that, but you can also walk. If you drive, park at the far end of the parking lot rather than trying to get to the door. And if you take public transportation, get off the stop before you would normally get off, and then walk that distance to give you a little bit of extra physical activity. And then the managing during the goals during pregnancy, you want your fastings to be less than 95. And after meals, you should be less than 140, 1 hour, and less than 120, 2 hours after the meal. Next slide. The dietary management things on the food are wonderful to tell you what's in them, but I do caution you, if you look at it, it does seem like this, if I had a bag of chips and it said that's what I could eat. But remember, you have to look at how many servings are in that container. And so for every single serving, there is 230 calories. And if you're looking at carbohydrates, you know, look at the total carbohydrates, so 37 grams. So that's 2 carbohydrate servings. So 1 carbohydrate serving is 15, so that's 2 plus. So that's like 2 slices of bread. So whatever this is, just say it's chips, and you had 1 serving, 1/8 of this whole container thing would be 230 calories, but more importantly, for managing your diabetes, it would be 2 carbohydrate servings. So that's a whole meal. So you need to think about also when you're looking at that, not just the container. It's nice to know what's in it, but remember that's for one serving. And you need to look at how many servings are in that container. So looking at figuring out what you're going to eat with that, if you're going to the cafeteria line or the buffet line, you can kind of eyeball how much you want to put on your plate. So that's a good way to do it. The other, next slide. Also thinking about what snacks you want to have. Fruit is great fiber, nutrients, vitamins, all that other kind of stuff, but it's also carbs. Fruit, very simple carbohydrates, and it's a very high glycemic load. But if you look at you can choose which. I mean, apples, the starch is good, and fiber, and carrots also. On the other side, donuts and linguine, cupcakes and pancakes and all that. But even the fruit, you need to be careful. Bananas are a higher glycemic load. So half of a banana is 15 grams of carbs. And so if you think about that, in the apples, if you're going to fill them in your hand, the ones that fill your hand, that's about 30 grams of carbs. So again, you can use your hand to kind of guesstimate and keep carbohydrates in a bay. Next slide. In addition to doing your hands, if you want to do your plates, and that's another easy way to, I think, easy, half of your plate can be vegetables. So you can go back 3, 4, 5 times, and many times you want, and you can have unlimited amount to fill you up. And then the other side of your plate, you can divide it into quarters, and half of it would be healthy carbohydrates, so whole grain, and then 1/4 of it would be healthy plant. Any protein, but a healthy plant. Any protein would be good to help keep the carbohydrates from being high glycemic load and increasing your glucose very high. You can also use olive oil. Olive oil is a great way to healthy fats, we'll talk about that, but avocados, but olive oil is a healthy fat, and that will also help to manage your glycemic index. And also water. Water is great as a way to get your kidneys to get rid of the extra glucose you're eating. Next. And then the snacking with our healthy fats is phenomenal. So any of these olives, these fatty fish, and in pregnancy, it's advised to have fish 2 or 3 times a week. So you can certainly have these as snacks. And you want to prioritize healthy fats, healthy snacks. So any kind of nuts would be a great idea. And avocados are phenomenal. And there's a number of menus, cooking books and meals using avocados for snacks and for meals would be a great way, and they're fabulous for improving your insulin resistance, and they're bulky, so they help to fill you up. So if you had that with the snack or had that in your meal or on a sandwich, would be a phenomenal way to do it. Next slide. And it's one of the reasons that it's really important to have the snacks, because if you see your glucose goes down, but then if you're not eating, then it goes way down, and that just won't work. So your glucose starts to get moved from where your body stores it, your liver, your muscles, and then sends it back up. And if you don't have the snacks, you're going up and down, up and down. And for fetuses, that's not a good thing, because when it goes up, it goes across the placenta, and then the fetus has to respond. But also for you, you're not feeling well. If you're hungry and you're denying yourself because you think you have diabetes, you're not going to feel good. So you may start sweating, and then it is not sustainable. So snacks are really important. It's not that you're not cheating. You just need to choose your snacks appropriately. Next slide. And then this is one of Michael Pollard's, I was saying, the book that I really do enjoy. Eat your colors. If you have a plate full of colors, different vegetables, and just make it very colorful, that is more likely than not to help you feel full, and also get your carbohydrate targets and get your glucose targets if you have diabetes. And then one of the things that Michael Pollard said, to avoid foods that contain ingredients that no ordinary human would have in their pantry. And if you look at some of these things, it's not likely you're going to have this. So high fructose corn syrup, unless you're going to have it on your pancakes, but even then you'll have the syrup as opposed to just that. And then other things you can't even pronounce. These are not things that you necessarily want to think about having. It just makes you think, well, maybe you might want to think about that. But these are, again, some things that Michael Pollard suggested you might want to think about in choosing your foods. Next one. And then I do want to just point out the physical activities. I said, park at the far end of the parking lot, or walk down the stairs if you can't walk up the stairs, or if you get off the stop before on your public transportation, because it's almost like a freebie. If you look at the top graph, the glucose increases after you eat, but if you go walking, even if you're just standing around cleaning up the dishes, and while you're doing the dishes at the sink, if you do some stepping, 4 or 5 times, 10 sets of tens or something like that, that will really help you to get your glucose down right after you eat. So that's a nice freebie. So just to think about walking all the time, some kind of physical activity. Next slide. Then the third pillar is monitoring glucose. We know about glucometers. And that's since the 1960s. Before that, we were using urine, which of course was not very reliable or responsible. But this glucometer is actually testing the capillaries, and then the continuous glucose monitoring actually is in the interstitial fluid. So it's not in the capillary. So there may be a difference, but the trend will be about the same in the glucometer and the continuous glucose monitoring. The nice thing, and if you look in the middle, the continuous glucose monitor is the graph that prints out, and you look at the four yellow spots on the continuous glucose monitor. That's when they check with the glucometer. Those are sort of like we would do glucometers 4 times a day. And if you look and see where they are, you can say that the glucometers are in target range. Everybody's great. But then if you have a simultaneous continuous glucose monitoring, you can see that in the interim, the glucose is going up and down, which explains a lot of what we were looking at when we looked at glucometers, and everything looked great. We didn't understand why the fetus was big, when the glucose targets were met, and what was going on. And it's because you look up and down, sometimes it's high, and that when it's high, it's going across the placenta to the baby. And so the glucose monitor, while it's wonderful, some insurances will pay for it in New York State. Most of our individuals who want it can get it. They don't necessarily have to be on insulin, but there's a real benefit, not just in being able to see what has happened, but if you have this and when you're walking around, you see your glucose go down, that's reinforcing that this is what you should do to help manage yourself. And it just helps to empower individuals in having control over their own health care. Next. And then if none of that works to get goals met, we move on to hypoglycemic agents. That does not mean the individual failed their treatment, and it does not mean they did anything wrong. It just means that we need more help in meeting targets. And the only thing that's approved and to use in pregnancy is insulin, although most individuals would be comfortable, most practitioners would be comfortable prescribing oral hypoglycemic agents. In the US, there's now been a push away from metformin. Throughout the world, metformin is used fairly commonly, in Europe particularly. The question of glyburide or sulfonylurea is an older medication, something that's been used for a while. I personally don't like it at all in pregnancy because how it works is by stimulating your pancreas to produce insulin. And so it kind of beats up your beta cells to make it produce insulin. Most often, because it's not auto-regulated, it produces too much insulin. So then you get hypoglycemic. Then the person gets hungry, so they eat some more. So then it gets up. And then for the baby, there's clear evidence that they end up having much more hypoglycemia when they're born because they're producing in utero more insulin because of the up and down with the resulting from the glyburide. But that is available for use. Next slide. And then another Michael Pollard's is don't get your fuel in the same place your car does, which I think, it's not that they have bad food, it's just the choices are limited. So you may have some peanuts, but often they're salty. So other things. So just some things, like I said, the book is, I think, just kind of amazing. Just thought about, I hadn't thought about that. But anyway, that's one of his things. Next one. So I wanted to, one of the things that got me interested in this is that this is something we know for a group of individuals who are at risk for cardiovascular disease, and we have a low-tech, non-interventional way of helping them to improve the outcome. And so that has been my motivation for getting involved in diabetes and actually really, really focusing on gestational diabetes as an opportunity to make a difference. And we know that individuals who have gestational diabetes, if they adopt lifestyle modification, that is regular exercise, 150 minutes a week, commit to losing 5 to 15% of their body weight. And I must admit, when I'm talking to people, I just do 10% because I can't figure that out. But I can look at their weight and tell them 10%. And then there is the opportunity to use metformin. You can use metformin, and it was almost comparable, but that never really took off. So most of the diabetes prevention programs are really just focusing on lifestyle modifications in order to achieve this goal. It's also been shown that women who breastfeed for 6 months can decrease their risk of type 2 diabetes by 50%. And then we still need to focus on the fetus, the neonate after it's born. Having been exposed to glucose in utero at that level increases their risk for cardiovascular disease, hypertension, and type 2 diabetes. So therefore, once they're delivered, we still really need to focus on the mother and help her understand ways to help her health and to prevent disease we know that she's more at risk for, but also for the fetus and the neonate and the pediatric patient, that these are risks that will go on, but they can be intervened and make a difference if we just pay attention. Next slide. So what do we do after they deliver? And honestly, only about some reports about 40% of individuals get screened after they deliver to see if they, one, continue to have just type 2 diabetes or diabetes, so therefore type 2 diabetes, or if they get screened just to see that it's gone away, and then have a plan of being screened every 6 months, every year, or whatever, depending on their other risk factors. These are things that can be used. What's primarily recommended is a glucose tolerance test in 4 to 6 weeks after, but fastings can be used as a screen, and these are the cutoffs, or A1C, not as sensitive, but it's better than nothing. But again, up to 40% of women don't get screened, and it's not until they come back for the next pregnancy, and oftentimes they have type 2 diabetes, so we even missed all of that. So next slide. And again, this is a summary, sort of our environmental risk factors for developing gestational diabetes are the same ones that are the risk factors for developing type 2 diabetes. And many of these we can't fix, obviously, but we can try, but at least we know they have them and can intervene and say that maybe using these lifestyle modifications or just being aware that you can do something to prevent or decrease, well, not necessarily prevent, but decrease the risk of developing diabetes, or at least delay the onset. And then the short-term complications during pregnancy, the preeclampsia. Again, most people who have had preeclampsia or gestational diabetes are at risk for developing hypertensive disease later on in life, so they need to be followed for that. And then again, the neonates too. Oftentimes, maybe Epic will improve this as our sort of our health records follow us through life. But many times people don't even know. Internal medicine doctors, if they knew someone had gestational diabetes, they almost always will manage them differently and help them. In OBs, we know that they have gestational diabetes, but oftentimes we don't. So the internists don't know that they have it, but if they did know, they would know what to do. OBs know that they have it, but we don't really follow them. And that really is a gap that I think it's not helpful and we can do better. Next slide. And this is my last one, and I can't believe that I had all these wonderful things to sell and enjoy and share with you, and that just didn't work. But I wanted to say one of the things that Michael Pollard said, don't eat anything your great-grandmother would not recognize as food. And my last question on this was one, please share any thoughts or questions you had about gestational diabetes. And then I also had a funny, but I can't do that because the thing's not working. Let me read some of these. Can I read? I don't know. Anything? Any chats? I do apologize. This was
Yeah,
so planned. I
there are
planned it so
multiple
well.
questions. I know.
Please, how should I do that then? Because I was trying to do
Well,
that.
if I can read them to you and
Okay,
you can
that's good.
respond.
And please accept my apology, everybody. I really thought I did this well. I was
Um,
good. Okay, yes.
one of them was um, whether or not all types of diabetes you've gone over, type 1, type 2, and gestational diabetes, are they all reversible?
Type 1 is not, because they do not have, there's a failure of the beta cell to make insulin for a variety of reasons. Type 2, there are cases of there are now thoughts that it can be reversed, and that's about lifestyle changes, weight loss, physical activities. People who had type 2 diabetes no longer manifest it. Whether it's actually gone or not, that's debatable. But yes, it can be certainly managed in such a way that they don't have hyperglycemia. And some of them don't need any insulin or any hypoglycemic agents, but can just be managed with physical activity and diet.
Okay. Another question is if the baby is growing well with the gestational age and the mother got diagnosed by GDM, does that always mean that the baby is going to be big in size?
No, if the baby doesn't develop hyperinsulinemia, they should not be big inside. However, you do need to still take into fact genetics. If the mom and dad are 6'5" and weigh 140 pounds, even if her gestational diabetes is well managed, it's going to be a big baby. So you still need to take into account genetics. But for the most part, if someone has gestational diabetes and they meet their glycemic targets, most of the time the baby is not large and they don't need to be managed indifferently. In fact, the recommendation is they're followed by obstetric indication, so they would be delivered and managed the same way as someone who didn't have gestational diabetes.
Okay. The other one was around, and you've talked about this throughout your presentation regarding the food rule. And there's one that's a little counter to what you have here, what your great grandmother would not recognize.
Mhm.
Wanted to get your opinion of the keto diet to manage blood glucose levels.
It's fine. It's just I think any diet is fine. The question is one, how long you can maintain it and
Mhm.
what the glucose values are on it. The I mean yes, any diet can is fine. It really is just a matter of what the results are on the glucose values, and
Mhm.
if you then are meeting all the other nutrients that you're getting enough vitamins and you're also getting proteins. So yeah, yes, there's no, I don't think there's any complete bad diet. It's just managing it and making sure that you're getting all the other nutrients that you need with it.
Okay. Well, I think I've taught all the questions that I see. There were some, I know that Marie, she'd answer some of the questions also. There was one out regarding gestational diabetes. Does that happen any other time outside of pregnancy? And I think that was answered in the chat.
Right.
So, okay. I
Okay.
know we are at time, but if folks will give us grace, we do need to close.
And I
And
do need to, please let me apologize. I really thought I had done this well, put all the,
you can clearly see all the work that you
No,
put into this. And you were
I
telling
think
us
we
all
lost
week
her.
yeah,
Did we lose Dr. C? Oh no, I
I
think
think
she
we
lost.
lost her.
She'll be
But she
back. She'll
put
be
so
back.
much work into this.
Bless her
She
heart. I
did.
know. I hate Mentimeter. We've had several speakers this week attempt to use it and it was not working. And each time it's a different thing. So well she'll join back in. But while we're
So,
waiting for her, I want to I'll let you remind. Do you want me to remind of how
yeah,
many
well, I was going
users
to
we
ask
need?
you,
Okay.
was there instructions for credit retrieval if you want to remind everyone on that?
Yes. So for nurses, there is a QR code. So I'll stop sharing Dr. Um, C's and I will share the code. And there is a bit.ly link. And I see that's why we can't do Mentimeter with bit.ly links. Um, and then for our doulas, you did not need to put your email in the chat. I'm not sure how that got misconstrued, but what you are asked to do is email our admin team at hello@birthingmagic.org. And I'll drop that in the chat as well. Dr. C, we were just chatting while we waited for you to come back to us, my friend. We wanted to tell you that please
I'm
do not
so
apologize.
sorry.
You are the fourth speaker this week alone, who attempted to use Mentimeter and it didn't work.
This is terrible. This is
Yes, it
terrible.
did not work. And several of them we did practice. I don't know if
I
maybe there's
practice,
like how it maybe like interacting with Zoom. I don't know what it is.
but it's not
Um,
Zoom. It's separate. It's a separate computer.
yeah,
I've been running it the whole time. I've been practicing
that's
completely
true.
separate.
Well, then the other
Completely
thing
separate.
is if people are on their phone, they can't do the QR code. But we
Well,
were
all I
just
can do is apologize.
reminding,
I am so sorry. I do
oh,
apologize.
please don't. Oh, wait. Sorry. Don't wanna, there we go. Just sharing the QR code for the team and the bit.ly, and I will drop that in the chat for you as well. Um, and for the doulas, for them to get their attendance certificate, email us at hello. But we wanted to just talk to you, doctor, and I have a couple of questions. We did not get to this, so we may have to invite you back for a part two. And then someone raised their hand. But one of the things that I know that when I first started talking to you about your research, that you educated me on was the importance of mom, if she is diagnosed with gestational diabetes, postpartum, what's the protocol that she really should be mindful of?
She needs to be tested with recommendations between 4 and 6 weeks. There are now studies going to look at whether you can test in the hospital. It really just need to know whether you continue to have diabetes. And then afterwards, you need to at least once a year get screened to see if you have diabetes. And because you just really are at increased risk. So it's one up to less than 40% of people get tested after they're pregnant. So it's recommended between 4 and 6 weeks you get a glucose screen.
Get a glucose screen. And so those of us who are nanas and aunties and nosy mothers at the
Be
church,
busy. Yeah.
if we hear that mama had gestational diabetes, we're going to
Yeah.
remind her
Screen,
four
four
to
to 6 weeks.
screen,
Four
4
to
to 6
six weeks. Yeah.
And someone raised their hand.
Please speak up. I just feel so bad. Yes, four
And
to six weeks.
I can unmute you if someone raised their hand. I don't know if that was intentional. If you raise it again, I can unmute you, or you can drop your question in the chat. Is everyone pretty much nurses and doulas? Are there any lay people in the chat or in the audience? I've seen a couple of you have attended most of our workshops this week. Thank you so much. Ashley, glad you're here. So since we do have at least one other person like me, there was at the very beginning, Dr. C, you shared, and if I could, and if you guys don't want to stay, and I know it's late for everybody, I'm on the West Coast, Kelly's on the West Coast, so it's like still early for us, so we got all day.
All day,
But
right.
I wanted to, if we could make this one slide a little more consumer friendly. Let me share it's the slide number 2, where you talked about the elevated risk of acute myocardial infarction.
That's what got me. That is what got me interested. It was in the 90s that just blew me away. If you have diabetes, you have the same risk of having a heart attack as someone who's already had a heart attack.
Wow.
Yeah. Yeah. And also I forgot to share that if anybody wants, I'm on Substack. I can to talk to people about that. But
I was getting ready to, I was trying to find your Substack account
yeah,
to
that's the wrong,
download
it's the
that.
wrong, that's the thing. This is the wrong slide
Oh,
that this is, I
we'll include
revised it.
it
I can
in
let me give
the
it to you. It is DPP at rockwoodpartners.com. That help. No. DPP at rockwoodpartners.health. So
and
DPP
we'll
at
put it
Rockwood Health,
got
rockwoodpartners.health.
we'll also include it with the recording. And
Yeah.
there were a couple of questions about whether we would share the recording. And yes, we do share the
Yes.
recording. We'll share the chat. So back on this slide. So when you say diabetes, if I have gestational diabetes, and then after I have the baby, I go in 4 to 6 weeks for my postpartum screening, and it comes back negative. Is that the right word? Or that
Yeah.
I don't?
Well, you could do negative is fine, or it just comes back you don't have an increased risk for diabetes. Yes. Yes. So you
But then
do
I
not
have,
have,
but then I will have a 12-fold increased risk
if it's
of
positive,
developing
if
type.
it's elevated, right.
Oh,
If
at
it's
that
elevated,
point. Okay.
right, right.
If it's elevated postpartum, then I
No,
have a
if it's elevated
12-fold.
postpartum, you have type 2 you have increased risk for type 2 diabetes. You need to have the 3-hour screen.
Oh,
But further in your life, you have a 12-fold increase over whatever your baseline is. So if you're, because of your family history or because of your weight, you have a say your risk for having diabetes is 4%. Because you had gestational diabetes, it is 40% now. So it's a 12-fold over whatever your risk is.
good. We're tracking with this. Okay. And then these simple modifications,
Can
they,
decrease it by 66%.
that is wild.
That's what
50,
that's what blew me away. I just thought, well, this is crazy and this is affordable, you know?
yes. Now where does, there was somewhere that you were talking about, metformin.
Yes,
But the,
that was in the trial where they showed that you could decrease the risk by 66%. So that is another option. That just never took off. The diabetes prevention programs, the DPPs, they almost all stayed with lifestyle modifications. But yes, you can use metformin to, if you have prediabetes, as a way to prevent developing metformin. However, metformin is a hard drug to take. It upsets your stomach and you have to take it for a long time, and people have diarrhea and bloating. So they don't really like it. But yes, that is another option. If you don't want to use if you don't want to use the lifestyle modification, you don't want to commit to that, you could certainly use metformin. My guess is, though, there's actually going to be some clinical trials with GLP-1s to look at individuals who have the prediabetes.
that's where I
Essentially,
was
is it?
going next, was if
Yeah,
there was,
essentially, the pregnant gestational diabetes is prediabetes, and so there are now some trials looking at GLP-1s to treat pre-diabetes, essentially.
Hmm. And Alicia has a question.
Hmm.
I just wanted to know if you could put the email in the chat for the certification.
Oh,
And I
yes.
just want
Thank
to
you.
say thank you so much.
Well, you're so welcome, and I am just so sorry for my technical challenges.
No, it was a great presentation. So I thank you so much.
Well, thank you for attending.
Thank you, Alicia. I just dropped the email, and then I think the bit.ly, oh, someone said they're having issues with the test. Let me stop screen share and I'll send the test again. You were saying, Dr. C, that the expectation is that they are doing, that they will, or they are currently doing studies on.
Yeah, GLP-1s for pre-diabetes. Yeah. Yeah, but GLP-1 for pre, but certainly you can use metformin. But again, because of the stomach upset and the gas and the diarrhea and all that, it didn't take off. And the whole idea is that this is a non-interventional, the lifestyle changes with diet and physical activity. So that's sort of what the focus is right now.
Okay.
Okay. Well, thank you all for letting me do this.
Yes, thank you so much. Guys, bear with me just a moment. I'm trying to drop, that bit.ly did not work, so I'm going to send you the direct link to the SurveyMonkey for the CE for the nurses. So if you're a nurse, stay on the line with me real fast, or send me an email and I'll send it to you if you guys need to go. Because my computer is doing a restart again. I think I have too many
Yeah, I'm not
windows.
having this is a bad technical time. So I feel I can't tell you how
It's
many
all
times I
type of,
did this to make
what do
sure
they
that they
call them,
both
gremlins?
work. I was on
Gremlins?
the phone with the Mentimeter. I mean, I just spent so much time and it was working. It was working. I couldn't even send you my correct slide. I mean, I didn't send you my final thing of slide. This is not good. I don't even know how
Well,
better to do it. I tried.
it's, you know what? Somebody said the tech gremlins. That's, I think, what we've been dealing with. But
I guess
you are the
I
fourth,
really tried.
you are the fourth presenter that we've had that it was working, they knew it was working, and then when we got
working, I
live, it
can't
was
tell you.
not.
I had the two computers right here and it was working. It was working.
So it's
Anyway.
more than a notion. Now, Dr. C, are we going to share the deck with the team, or we'll just share the
Well,
report?
let me send you the final one and I'll share it. Because this was
Okay.
not the final one. Yeah, I'll
That was
send
one of the
you.
questions as well. So we'll.
Yeah, I'll
we can-
send you the final one. Because I did make some revisions and made a final one and I ended up not sending it. Thank you, Ms. Nelson.
Thank
I'm
you.
so sorry. Thank you.
so
Thank you.
much.
Thank you. I
No,
just so
thank you.
apologize. I apologize. I feel
Please
terrible.
don't. You really did a
I
beautiful
do.
job.
You
I
did.
do.
I don't know.
You
I
put
hope
so much
everyone else
work in the
felt
charts. You can see that, all the
as
work.
bright as I did.
I tried. God knows I tried. Oh,
Oh, here we go. Okay, we've got the Survey Monkey code for. So look at all the love. You've got all the love in the
thank you.
chat.
Oh, thank you. Because I do feel bad because I did try to make this work.
Okay, I've just dropped the Survey Monkey, and I will
I'll-
send it in the email with the recording and
And my
with
my real slides. I'll
the-
send you the final
the
slides.
deck.
Yeah.
And we just, as her friend and agent, we just ask you guys not to use her proprietary information and create your own presentations.
Yes.
So
Okay.
thank you guys so much.
Thank
Thank
you
you,
so
Dr.
much. Take care.
Steve.
Bye-bye.
Love
Have
you
a good
so much.
night. Take
Yes,
care.
have a great
Bye-bye.
night.
Thank
Take
you.
care.
Bye,
Bye-bye.
Kelly. It was nice meeting you.
Nice meeting you too, Dr. Henderson. Take care.